Hi guys, in this video we're going to walk through assessment and plan of a virtual patient that I created out of a bunch of patients that I treated in my intern year, and I'll share with you how I write my assessment and plan. So in this case, this story is of a made-up patient in her 50s, wheelchair bound, homeless, IV drug user, came in with cellulitis. So the number one problem I wrote was severe sepsis. Source: cellulitis of bilateral lower extremity in the setting of IV drug use with AKI. The reason I wrote severe sepsis as opposed to cellulitis, you could write cellulitis, was mainly for billing purpose. Severe sepsis gets billed more than cellulitis. Quickly, I wrote the source and I wrote the reason why it's severe sepsis and not sepsis alone, and the reason is AKI. So this is mainly to help the billers in the hospital. Now in terms of plan, I wrote what we will do. So we will get a urinalysis, we'll get a chest x-ray, we'll do a urine chlamydia gonorrhea to look for other source. In this case, the patient wasn't I couldn't get a reliable history. That's why I was fishing for other sources. Now let's see if this patient was able to give me a nice clear history of exactly what happened. You know the source is cellulitis. You don't need to check for all of these other things. The other I wrote about the antibiotic. It is really important to write the antibiotic start date. The frequency and dose not too important because those are standardized, but the start date is really important because antibiotic need to be continued for a fixed duration of time, and when it's started becomes really important as discharge. So the patient got vancomycin on this date in the ED, and I wanted to do vanc for 5 days, and I briefly wrote my reason is because she uses IV drug and I want to cover her MRSA. And the other thing to do is that I want to get the ultrasound for phlegmasia, which is sometimes people can get a DVT and that can get infected, which is called phlegmasia. So I wanted to get ultrasound, and I briefly wrote about my pain medication plan as well. So this is the usual level of detail I go to, and that's the main problem that she came in with. The other problem was her AKI, most likely pre-renal, from sepsis and reduced PO intake, electrolytes largely okay, strict in and out to monitor urine output. And that's all I was going to do. Now, and sometimes people may want to follow like FENA labs that can tell if it's more likely to be a pre-renal etiology. Personally, I don't like to do too many labs. I have talked about that in my other videos. One is that it only causes extra work for me because I need to follow up on the results. And number two, it increases healthcare cost. And many times, if I'm kind of sure why something's going on, then I don't really need to get labs. I mean, in this case, she's septic. A lot of time people who have sepsis has pre-renal AKI, and I was just gonna monitor in and out to see how much urine she makes. The other problem she had was also she was hypoglycemic on admission, and the story was that she was doing drugs, just found near a dumpster for unknown amount of time, so she was probably not eating. So one of the problem, hypoglycemia, this resolved, and the other problem was her drug use, IV crystal meth use. And I consulted social work for disposition, meaning discharge planning. And again, I want to encourage you guys to think about discharge planning from the day a patient walks into the hospital, because her cellulitis, I mean, that's easy to treat, but she's homeless, lives out in the street, does IV drug. Is there anything that we could do that would potentially prevent readmission? And one thing we could do is to consult social work, see if they have any resources. So again, think about discharge from the day the patient comes into the hospital. The other one was that she had basal ganglia hemorrhage as well. This is a made-up date, due to meth use. She's wheelchair bound at baseline. Now, some people may write baseline neuro exam here. I personally don't like to, because I like my assessment and plan short. If someone wants to know this patient's baseline neuro exam, then they should go to my physical exam section, or I would write the baseline neuro exam. And in this case, the only thing I did was I consulted PT for discharge planning, because again, think about discharge from the day someone comes into the hospital. Other problem patient had was, hepatitis C, no history of treatment, nothing to do in acute setting, and one can argue that this does not even need to be an assessment and plan because I'm absolutely doing nothing for this. I could just have written untreated hepatitis C in the problem list, and that would be okay. The other problems she had is this, some kind of psych disorder. I wrote that she does not have any acute exasperation, and I was just going to continue her home medications. And again, I like to describe if something is a home medication or not, because that becomes important at the time of discharge. For example, in this case, when she goes home, we'll just send her home with home medications unless we feel a need to change it. The other problem is this coronary artery disease. Now, if it was a busy day, I didn't have too much time, then I could just have, assessment, nothing, and plan just continue her home medication. This day I had some time, so I wrote her echo done in September 2018 and Lexi scan were unremarkable, but she came in with sepsis. I really don't have to do much with the heart, so if I was busy, I could have just left all of this out and just written that continue home medication because I'm doing nothing for this. The other thing was that gastric bypass surgery, and again, I'm doing absolutely nothing for this. Someone could argue that this could be left in the past medical history section and not an assessment and plan because I'm doing nothing. And also this, this should not be the plan because that's not the plan. The other problem is anemia of chronic disease. Again, one can argue that this could be just left in the past medical history because again, I'm doing nothing about, well, I guess I am recommending her for meds assessment, so I'm doing something. Hypothyroidism, I was continuing her home medication. Asthma, so in this case, I just wrote continue her home medication. If I had more time to dig into the chart and do more history, I could have, asked her hey, how your symptoms are, so that I could have described whether it's intermittent, persistent, or what kind of asthma it was. She was breathing comfortably, didn't seem like she was in any respiratory distress, so I didn't feel a need to really dig into the assessment of her asthma. Hypertension, we're holding her home medications in setting up sepsis, and she also had a AAA, and she had a CT angio done on this date that shows this, repeat CT angio around this time. And again, one could argue that this does not have to be here because I'm absolutely doing nothing about it. So in summary, there's different ways to write assessment and plan. I want to emphasize being brief and to the point, and mainly talk about plan, mainly talk about what you're going to do, because that's what other people are interested in it. If it's too long, too detailed, then it just gets confusing and the chance of error goes high. Thank you so much for watching my video.